Good morning, everyone. My topic today is One Airway, Many Roads. Good morning, respected chairpersons and all the delegates present here. I am going to compare the protocols across borders. Presently, there are several guidelines on difficult airway management across the world. American Society of Anesthesiology first published their guideline in 1993, and thereafter they have updated the guideline every decade, and the latest guideline is published in 2022. Difficult Airway Society of United Kingdom was in the picture since 2004, and their latest publication is in 2015, and Awake Tracheal Intubation Guideline was published in 2019. All India Difficult Airway Association, our Indian guideline, first came in 2016, and their update is due this year, and we are expecting this by December 2025. There are several other guidelines like Canadian Airway Focus Group, European Society, Chinese, Brazilian societies who have postulated difficult airway guidelines. All these guidelines have situation-specific guidelines like unanticipated difficult tracheal intubation in adults, in obstetric subgroups, in pediatric subgroups, in critically ill patients, and they have also categorized anticipated difficult extubation management guidelines in their protocols. Today, we shall be focusing on the first segment, that is unanticipated difficult tracheal intubation in adults. All the societies have defined the situations. Let's not get into the details. American Society of Anesthesiology and Canadian Airway Focus Group have categorically defined this difficulty and failure. They have defined difficult intubation as taking more than one attempt and failure as taking more than 3 attempts. Actually, failure means 3 attempts, 3 unsuccessful attempts. This is also applicable for supraglottic airway device placement. In their current guideline, American Society of Anesthesiology have coined a term, difficult extubation or at-risk extubation. They have defined this term as loss of airway patency and adequate ventilation after removal of endotracheal tube in a suspected difficult airway patient. I am requesting everyone to pay attention to this basic framework of difficult unanticipated airway management guideline. Actually, this is the basic framework upon which all the other guidelines, they are framed. So here, the first step is the conventional laryngoscopy and intubation, failure of which results in the next step, that is supraglottic airway device ventilation. If that fails too, then we end up in final attempt at face mask ventilation, and this failure ends up in a very crisis situation, and the management depends on primarily surgical airway establishment. This is All India Difficult Airway Guideline 2016. Today, I shall be focusing on this guideline and compare all the other guidelines on the basis of this. Let's zoom in. The step 1 of All India Difficult Airway Association guideline. You shall be noticing that these steps are named as, like in the previous one, Plan A, Plan B, Plan C, Plan D in this Difficult Airway Society guideline. The same is termed as Step 1 in All India Difficult Airway Association. So when the first attempt at laryngoscopy and intubation fails, then All India Difficult Airway Association has categorically mentioned that maximum 2 more attempts are allowed, considering the saturation is more than 95%. And during these 2 subsequent attempts, they are suggesting optimizing position, considering change in device, technique, and asking for more experienced operator between these attempts. and they are forcing to continue oxygen nasal flow at the rate of 15 liters per minute, as well as maintenance of depth of anesthesia during this whole period. If this step fails, and they have also mentioned calling for help at the very first step. Now let's compare this step 1 of IDA with others. IDA has mentioned pre-oxygenation and peri-intubation oxygenation in the form of nasal insufflation, high-frequency nasal oxygen, and Thrive. ASA and DAS has also categorized Thrive. In addition, DAS had termed no DSAT. That is an acronym that stands for nasal oxygenation during efforts of securing a tube. And the number of attempts, like All India Difficult Airway Association and Canadian Association, have allowed maximum 3 attempts, whereas DAS and ASA have allowed maximum 4 attempts. Like after endotracheal intubation in position, the conformation of ET tube, all the guidelines have categorized as capnographic conformation. Only IDA, you can look at the down right side, only IDA has mentioned continuous waveform capnography and presence of 6 consistent capnograph traces without decline as the confirmatory test of tracheal intubation. Now coming to the last portion, the ASA guideline, in the ASA latest guideline, they have pointed out a new concept of pre-intubation decision-making tool. I shall be showing it later on. And they have also emphasized on time, number of attempts, ventilation, and saturation monitoring throughout the entire process. And they have recommended that if an individual technique has failed, then going for combination techniques. Now let's come to the step 2 of IDA. In step 2, when the intubation has failed and we have taken decision to place the supraglottic airway device, IDA has mentioned maximum 2 attempts can be taken at placing this supraglottic airway device, and preferably 2nd generation. The right side consideration, these points, just note when I am comparing with the other guidelines, the same considerations are termed exit strategy option in Canadian guideline. The same points, awakening, temporizing with supraglottic airway device, surgical airway, these are mentioned as exit strategy. And the number of attempts, IDA has mentioned 2 attempts, whereas Canadian guideline and DAS guideline has mentioned maximum of 3 attempts can be taken for supraglottic airway placement. Now, the final attempt at face mask ventilation using optimum technique and ensuring neuromuscular blockade. If this fails, then IDA has termed as complete ventilation failure. Here comes the panic button, the invisible panic button is pressed. Here comes the importance of human factor. The guidelines that mentioned human factor are ASA and IDA, but specifically ASA, the American Society of Anesthesiology, have categorically defined and categorized this human factor. Now, the complete ventilation failure that was coined by IDA, the term changes with other guidelines. DAS calls it CICO, can't intubate, can't oxygenate. Canadian guideline calls it CVCO, can't ventilate, can't oxygenate. American Society calls it CICV, can't intubate, can't ventilate. Now the last step, when there is complete ventilation failure, IDA calls it emergency cricothyroidotomy, whereas the other guidelines like DAS and Canadian guideline calls it FONA, front of neck access, and ASA calls it emergency invasive airway. ASA is the only guideline which tells about ECMO. It calls initiation of ECMO when or if appropriate and available. Here you can see this emergency FONA is mentioned. And just focus on the above portion. I was mentioning this pre-intubation assessment tool. The ASA latest guideline, it has mentioned this tool, and it categorizes, it differentiates between the pre-operative, pre-intubation decision, whether awake intubation or intubation after induction is feasible. Now this is Canadian Airway Focus Group. This is my last slide. This is Canadian Airway Focus Group guideline. Here you can see the exit strategy, FONA, CVCO are mentioned in this guideline. Now, regarding video laryngoscopy, all the guidelines have mentioned that preferably video laryngoscope should be used. Canadian guidelines have categorized that video laryngoscope should be used as the first attempt to ensure success. And they have mentioned that lesser complication rates with video laryngoscope. So be prepared for, don't be like supreme confident. We have to learn the guidelines and be prepared for the situations. Thank you.